Thank you very much, Chair. Thank you very much to the African Union for hosting this important event and also for collaborating with us on that. I think thank you to all the speakers who have provided a lot of fertile ground to share some of our work also on and also to discuss some of the challenges that we still face. I will be sharing my screen all the time, but I'm not going to present on my own. But in collaboration with the AU, we decided to share our story of Gold3, how we are leveraging a combination of innovation, capacity building, technology, and a lot of other factors to really try to transform the health systems. And basically, this is to provide a high-level overview of that. In that journey, we as Gold3 have partnered with several ministries of health, including Malawi, Tanzania. But today with us are really the Rwanda Biomedical Center or Rwanda Ministry of Health and the Rwanda Pediatric Association, because collaboration and innovation, as is the theme of the webinar, is really they go hand in hand, because you can't change. Innovation is change, and you can't change without collaborating. And I think that is really key to what we are doing and what we're discussing. So my name, again, Niek Versteegde. I'm the founder and CEO of Gold3, which is a social enterprise. Some may have received information that's a foundation. We also have a foundation, but we're a private company with a foundation. And the lens I would like you to take today is emergency and critical care. And this is a quite specific lens because it's about thinking about all the conditions, acute conditions. So we're not talking about chronic conditions, but it's about conditions. If you recognize and treat them in time, patients will will recover and lead a normal life. And for most of these conditions, including diarrhea, including malaria, including pneumonia, including neonatal conditions, including maternal conditions, it's not that we don't know what to do. We already resolved many of these conditions or how to manage them decades ago, if not longer. And it's really about how do you organize it when you have so limited staff and resources. And that's really the challenge. And that's also what I've experienced myself while working in a district hospital in Tanzania. So when you have to provide any kind of care, but especially also in emergency and critical care, and you do not have enough staff and not the right equipment, it sets off a vicious cycle of reactive care, whereby as a doctor or a nurse, you constantly run from one emergency to another, intervening at the later stage when treatment are least effective, are more time consuming, and put more pressure on scarce time and scarce resources. So setting off a vicious cycle, aggravating a situation which is already poor. To help to address this challenge, we have developed a technology platform that we call IMPALA that consists of multiple elements. And one of the key challenges, and that's what I really liked about the talk from the African CDC about infrastructure, it's about how do you create reliable infrastructure, equipment that works in the setting and remains working. And that is what we have done when we set out to engineer the IMPALA monitoring device to create something that is robust, durable, and easy to use, and that can be maintained and sustained in the local environment. So that can really help to work, but also creating something that health workers who very often did not have much training, not as much at least compared to Western settings, who are very busy because they have a lot of patients that they can intuitively use and on the job. And that's really what the IMPALA monitor does. It's a tool that works, remains working, and that everybody can use, and that helps to unburden the health workers by automating repetitive tasks. Then secondly, it's about creating that information in a way and unlocking that in a way that it's accessible for health workers. who are doing other tasks and who have multiple patients to look after. So we created a central patient overview, which can be installed on a large or small screen in different configuration depending on the context, that uses a traffic light system and patient avatar to create a very intuitive format for how patients are doing, which ones are improving and which ones are deteriorating, allowing health workers to escalate care when it's needed and to de-escalate care, maybe refer a patient home or discharge to the general ward when it's needed. Again, optimizing the resources. And by creating this overview and making sure that this information is available where the health workers are working, we allow them to provide proactive care. Moreover, the whole system is built on a robust IT infrastructure that we also provide. So all data is stored locally on a server which has internet connection but does not need internet connection, and the whole system has a battery backup that lasts over 10 hours. Basically, how do we make sure that it works and remains functioning in this setting? We have technology is always just part of the solution because it's about people, it's about processes, and how do you induce change in a very challenging environment. So we have a strong service model in which we leverage project funding to do an initial assessment, talk to the health facilities to see how is care currently being provided, why is it provided like this, and how can we improve that leveraging the technology, but also the training and implementation approach, whereby we really emphasize local ownership by creating a champion on each ward where we work, so that we really make sure that there's an owner for the success of the Impala system and that can share the results with can share the training and training materials and provide support to the peers on the job. And this is very similar to what Carolina from Lardal just told. It's about providing health workers with the skills, knowledge, and tools that they need to provide the job. And then, of course, we install it. But also beyond the initial installation, we focus really on how do we keep sure it remains working. So providing maintenance, spares, consumables, anything to make sure it has a high uptime. So we achieve about 98+% uptime. We provide software updates and upgrades because basically this creates a layer of infrastructure to which we can add new clinical applications, and that we can unlock the data for other purposes. And then Goal 3 Academy. How do we continuously support the health workers in training and upskilling themselves on the job? And that is really about, so this is about enabling proactive care to break the vicious cycle. Based on our results to date, and to be clear, we are in existence since about 6 years now, so we're still relatively early in the journey. We're now active in 13 hospitals and already have 28 new hospitals to be funded, which will be implemented over the next months. But from the first sites, over 12 to 24 months of follow-up, we see a 27 to 42% reduction in mortality in neonatal and pediatric care. Over 90% of health workers report that after implementation, stress levels have reduced and workload has reduced. And if you extrapolate these results and look at the cost effectiveness, which are internal calculations so far, we see that the neonatal mortality, preventing one neonatal death was about $105, and one pediatric death was $208. And benchmarked against, for example, artesunate for malaria, that's 1 to 3 times better than that. From Malawi, from 2 pediatric care settings, we have done an extensive cost effectiveness analysis, doing a before-after comparison, looking at the impact on cost and mortality. There we saw that it marginally increased cost by $3 per patient, while the cost savings were significantly higher than that, both to the health system as well as to the patients. Basically, because patients not only recover more often, they also recover faster, they go home earlier, and this leads to cost savings. We also see a strong drop in critical illness events by 24%, so less resuscitations, less unexpected problems with children. The shorter admission time in it was 47% was in the high dependency unit, and at ward level there was a 26 to 42% drop in mortality. And that's where we are currently really preparing for the next phase for scale up. We would not have gotten here without collaboration. So, like I said, we collaborated with multiple ministries of health, but Rwanda really stands out. So we have established a collaboration 2.5 years ago with the Rwanda Pediatric Association and the Rwanda Biomedical Center with the intent to pilot and do a phased introduction and then a scale up of Impala. And that is how we went through this journey. So from here, I would like to hand it over to the Rwanda Pediatric Association with Prof. Lizine. So Prof. Lizine, welcome. The floor is yours.
Thank you so much. Thank you to the organization which invited us to present this collaboration with GOR3. Next, please. Next. Okay. So as the Rwanda Pediatric Association, you're collaborating with the NGOs, with the Rwanda Ministry of Health, and we can highlight that we have some challenges in pediatric and neonatal care in the country, and we have also opportunities for improvement. So for challenges, we have limited access to appropriate neonatal and pediatric monitoring equipment as other African countries. So we have a kind of manual and inconsistent vital signs monitoring, especially in rural hospitals. We have also a challenge of high workload and a limited number of staff. So, but we have opportunities for improvement as we talk about digital innovation since this morning. So it's one of really opportunity to improve patient care. So we can say also we have opportunity about the commitment of our top leadership with a clear vision to reduce neonatal and under 5 mortality in the country. Next. So from those challenges, we started to collaborate with GOR3 on a very nice project. We have a joint implementation of the IMPALA Pimani study, which is a research focusing on improving pediatric and neonatal care at 2 district hospitals and 1 teaching hospital in Rwanda. So how the IMPALA monitors help us in this study? So we start to see that it provides the real-time continuous vital sign monitoring of pediatric and neonatal patients. It enables early warning alert to support timely intervention. It reduces also burden on clinical staff and improve timely decision-making. But also it's helped to capture and store data for research and quality improvement. Next. So with this research, we started to see some result already. We observed positive reception from our nurses and the doctors working in pediatric wards. IMPALA Monitor successfully is integrated into workflow, and the staff reported improved confidence and efficiency in monitoring patients. So they believe that they can provide adequate services, free up their time because early intervention are less complex and no manual monitoring is needed anymore, and improve their work fulfillment. So they noted also improvement in early detection of patient deterioration, reduced reliance on manual monitoring. And in 1 district hospital already, we started to notify that there is 3.5% lower absolute mortality in the first 5 months after IMPALA implementation, compared to same 5 months prior to this implementation, which is equal around 32% relative reduction. This is really kind of a good outcome, but we're still observing those outcomes because the research is still ongoing. So our next step, we wish to scale up this monitoring system using IMPALA monitors to more district hospitals. And we continue to train and provide technical support to our pediatric team. Over to you, Thierry.
Thank you very much, Professor Levin, and thank you as well, Dr. Niek. Good afternoon to everyone on the call. My name is Dr. Thierry Sewakunzi, and I coordinate digital health initiatives here at the Ministry of Health. And specifically for today, maybe I'll give you an overview of the Rwandan health system and policy context as regarding to the IMPALA system and what has been done so far. So we as a country, we also align our strategic plans and maybe our priorities with the Agenda 2063, but we also have currently the Health Sector Strategic Plan 5, whose vision is aims to have a healthy and productive population that contributes to the realization of Rwanda's development goals. And the HSSP5 has 5 pillars, which I could call priorities. But of course, under those pillars, there are also other priorities and interventions related to those pillars. So specifically for the IMPALA system, it aligns or relates to 4 of the 5 pillars here, and that is health workforce, health infrastructure modernization, quality of health healthcare through PHC, and then research, innovation, biomanufacturing, regulation, and digitization. And maybe just to also take you through the baseline that we had when IMPALA began and where we want to go and why IMPALA again, maybe just to also outline that, is that in 2023, as you can see here, we had on the maternal mortality ratio, we had a ratio of 105 per 1,000 live births, and we want to reach 60, similar for under 5 mortality rates on neonatal mortality of 45 and per 1,000 live births to we're targeting 20. Same thing as my colleagues mentioned earlier on with the health workforce density, where we are below the target recommended by the WHO. We want to also make sure that we also increase our workforce. And with this, we have what we're calling the 4x4 initiative, where we envision to triple the number of health workforce by 4 times in 4 years. So we expect by around 2028 we will have reached the target, but by 2029 our target is 4.8 per 1,000 population. Similarly to health facility coverage. So with maybe continue going ahead with the IMPALA system. Next slide, please. Yeah, so our collaboration with the IMPALA system is a partnership that began 2.5 years ago. So probably around 2023, where again, we've had a collaboration with multiple stakeholders. So the Rwanda Biomedical Center, which is our implementing agency of the Ministry of Health, we've had from the Rwanda Pediatric Association, and then also a local organization called Linda Ubuzima, which we began with a pilot system or a pilot study, which is called the IMPALA Pimani study. And that pilot study has been in 2 hospitals. That is Nyamata Hospital and Gwamagana Hospital. And I specifically put them here for those who are interested maybe to come and see exactly how the system works. You're very welcome. And we've seen, as again, my colleagues mentioned earlier, we've seen a 32% reduction in neonatal mortality. And for Gwamagana specifically, it was maintained at where it was. But I think also one of the most important aspects was the reports from the health workers, who are usually in the settings that they're in are usually overloaded, but with the IMPALA system, 90% of them report an improvement in efficiency, but also reduced stress and reduced workload. This plays a very big factor in the quality of care that we give, but also in the outcome of every patient that is into these wards, be it pediatric and so on. So now maybe next slide. The next slide just wants to show you maybe the results from the study, which I think we've emphasized much. I think they are very self-explanatory, so I will not spend much time onto that. Maybe I'll go on to what's next, the next step. The IMPALA Pimani study is still going on. But maybe for us, I think with the data that we've had and the data that we've seen from Tanzania and Malawi, we feel that this is already a very important initiative that could work for us in our context. And we're looking into a scale-up into other hospitals after the pilot study. And currently with phase 1, we are focusing on neonatal departments. So that is the NICU, and then also the pediatric wards. And so far with our calculations of the costs, I think I saw someone asking how much it costs to do that. We've been able to identify a need of 2.7 million for the one-off costs for the installations, and then of course the recurring costs, which again the IMPALA, the Goal 3 organization provides with the maintenance, but then with the recurring cost of 615. But maybe don't look at the money so much, because it could well, in some contexts it's small, in some contexts it's big. But when you look at the impact of the scale up, we're looking at 2,435 lives saved annually, with a cost of $4 per life each year, not just a month, but each year. So this impact in itself for us gives us a basis for decision and say, let's go ahead with a scale up. We are confident that this is going to serve our people well. So with the scale up, the vision really is nationwide deployment.
May I request that you summarize, as we are way beyond time? Sorry.
Yes, definitely. Yeah, so with the scale up, the vision is nationwide deployment of IMPALA systems. I mentioned that phase 1 was in pediatric and neonatal wards, but we are also looking at entering in maternal wards and also maybe internal medicine in the ICUs. So we've already outlined collaborative roadmaps, also integration strategies, and also funding sustainabilities. So because of time, allow me to pass the room again to Dr. Niek to just conclude and finish the presentation. Thank you.
Yeah, thank you so much, Prof. Lezine and Dr. Cherry, for doing that. Maybe just some key lessons here, and because I think that's what we're here today. So I think one of the key lessons I learned: innovation doesn't happen. It's something that requires a collaborative effort to really drive innovation, because change always takes effort. So relationships and partnerships are really essential. Evidence, like Dr. Cherry said, is essential. Show me, don't tell me, including the scientific evidence, and we understand that. That's really needed. It takes time and it's costly, especially if you target public health sectors. It's quite slow. So philanthropy and grants have been essential for us. There are still a lot of bridges to cross. We're definitely not there yet, but we're not alone, and we feel that in the partnerships that we have. And we're dedicated to make it work and identify any challenges that may arise. And as Dr. Cherry said before, Rwanda has volunteered to really provide demonstration visits for anyone interested who's in the neighborhood. Back to you, Chair, and apologies for taking a bit more time.